Okay, hi everyone. Today, on this episode of the REFERROLOGY series, we'll be talking about practical dermatology with Dr. Ellie Choi, who is a dermatology senior resident. With me, I have Dr. Sean Tan, who is a fellow resident in internal medicine, and he also has a keen interest in dermatology. So, of everyone in this room, I'm probably the most clueless about dermatology. So let's dive in. So, just an overview. Today, what I hope to cover is for Dr. Ellie to give us some tips and insights into common approaches. Firstly, maculopapular rashes, and secondly, blistering rashes. Secondly, would be that of common conditions, how we can initiate basic management. The third is about steroids. And fourthly is when we should be concerned. I think it's we don't expect to be able to diagnose all these complex dermatological disorders after the end of this session, but at least most importantly is to know when to escalate things. Okay, maybe we can start off with Dr. Ellie. So I'm sure you've probably received 1 million referrals for maculopapular rashes, and that's probably where the referral ends after the resident says, I have a maculopapular rash. So maybe you can tell us how we should approach this, what we should be looking out for before we give you a call.
Right, so I think maculopapular rash is one of the most common rashes that we see, and patients usually can even present with these rashes in the hospital because it's usually very acute onset. So I think first, when we look at the history, the important history that we usually ask that would be good if the residents were also able to elicit would be, apart from the onset, the day, how it has progressed. So whether it is getting worse, getting better, and usually how we know that it's getting better is not just whether there's any new rashes coming out, but also whether the color is starting to fade. Maculopapular rashes usually become more brown, so that's a way you can tell whether it's improving. The second thing that I think is quite important in the rash onset is where it started off from. So some rashes tend to start more centrally, whereas some rashes tend to start more acrally and spread either like centrifugally or centripetally, and that one is quite important as well. People like to ask about itch and pain. That does have some particular significance, which we can talk about a bit later. And I think the last thing important is whether there's any like red flags, which will be things like mucosal involvement, skin pain, which we can also talk about later. Then in terms of the different causes, the causes would be things like para-infectious and drug. So those two things would be things to look for, any infective symptoms and any drugs.
Okay. So maybe just to lead on to some of the things that you just mentioned. So in terms of pattern of distribution, what does starting on the trunk suggest, and what does starting on the acros suggest more?
So usually things that start, this is very broad. There are of course a lot of exceptions, but usually when things start more acrally, like palms and soles, we tend to think whether there's something like para-infectious, like erythema multiforme that can start on the palms. When it's more central, sometimes with flexural involvement, that can be more suggestive of a drug rash. But at the same time, I think there is a lot of cross between the two. So that itself, by itself, is not very, very useful.
Okay. And so you mentioned drug-related rashes as well as para-infectious, which probably would be probably the two commonest that we see. Is there any way clinically to help to differentiate the two besides the history of either drugs or rashes or any infections recently?
So this is something that we always ask ourselves as well, because when we see a maculopapular rash, we also always ask ourselves, is it para-infectious or is it drug? In terms of the history, if you have a very clear-cut drug, then that's more likely drug, of course. And then para-infectious is if you have any infective symptoms. But a lot of times, patients don't particularly have any infective symptoms. They're not really febrile, so that can be a bit borderline, but yet it's still para-infectious. In terms of the rash morphology, when it's a drug rash, sometimes the area tends to look a little bit more dusky, a little bit more purplish, and if you have eosinophilia, that will also favor a drug eruption.
So what kind of drugs are we actually looking at usually when we talk about a culpable drug?
Okay. Usually the drugs that are very high risk would be things like antibiotics. It's very common that they get either in the hospital or outside. Then you also have things like your traditional very high risk ones like allopurinol, Bactrim, anticonvulsants. All these are very high risk of getting drug rashes. And we always want to ask about TCMs and supplements as well. It's not a common cause of drug allergy, admittedly, but these are things that is very easily forgotten to be asked. The last one will be painkillers. So a lot of times opioids, NSAIDs can also cause a rash.
Okay. So maybe just a quick word on the different types of drug, or rather like dermatological manifestations of a drug rash. Because I mean, so maculopapular is one of those that we see, but at the same time, there are also others like fixed drug eruptions, more severe things like, let's say, DRESS, SJS, and things like that. How should we think about drug rashes from a clinical point of view?
I guess, I mean, the most important thing that you look at is the morphology. So maculopapular is the most common. The other one that sometimes people confuse with MP rash is an urticarial rash because they both look pink, they both look raised. The difference is that an urticarial rash would be more fleeting, means the individual high flight rashes, they come and they go very fast. And that itself is usually the most helpful feature to differentiate between urticarial and maculopapular. Urticarial
Severity of complications are both about the same, urticarial rashes versus MP rashes.
Yes, yeah. Anyway, they are both generally considered non-severe cutaneous adverse drug reactions. Urticaria, of course, it can be associated with angioedema, anaphylaxis. That'll be more worrying. The other difference between the two is that the urticarial, the drug latency is shorter than a maculopapular rash. So maculopapular rash, the rash may start a few days after you take the medication. But for urticarial, it's usually within like half an hour to an hour if the host is sensitized before.
Okay.
So MP and urticaria are the most common ones. Then you have the other ones like fixed drug eruption, acute generalized exanthematous pustulosis or AGEP, SJS-TEN, DRESS, and all these be diagnosed based on the morphology, for which there are certain differences between them.
Okay. Okay, next up, drug chart. I think this is what residents kind of dread because it's, yeah, we need to plow through the EMR. So what are your tips on being efficient and effective in coming up with a good drug chart?
So I think first is when you make the blue letter referral, if you tell the dermatologist that you're considering a drug, then definitely you would ask for a drug chart. If you don't think that it's a drug, then you may not want to mention it, but then that also takes some knowledge to think whether or not you think it's a drug cause, which is a bit like what we discussed earlier. Once you are asked to make a drug chart, usually in our institute, we like it in an Excel form because that shows the temporal sequence. One very common mistake that residents make is they do a drug chart after the rashes have started. Then that's completely useless because you're actually looking for drugs before the onset of the rash. Sometimes it's important to also know a bit after the rashes because we want to look at the temporal sequence. So if the rashes are worsening, it's likely that the drugs are still on. Whereas if the rashes have gotten better, whatever that is still on is unlikely to be culpable. Because if the rashes are getting better, then and you're still taking the medication, then it's unlikely that medications are culprit.
Okay.
So then, making the drug chart, we find, so for patients who are already in the hospital, that's when it can get a bit problematic if they have a lot of medication. What we usually feel that is the most important that you should like never miss would be the antibiotics, any like anticonvulsants, what else? Contrast is something that's very important that people don't always include. So contrast for like CT scans, angiograms, MRI contrast as well. A lot of times, you know, people chart like the drips, the potassium, magnesium phosphate replacement. That one is not so important, but generally, if you're not very sure, it's good to include it, but you may not need to like chart like a dose by dose kind of basis. Whereas for things that like contrast and the rash is shortly after, then you might want to put the time inside.
Okay, thank you. That's really
How would you differentiate between multiple drugs? For example, for someone on pneumonia, they will have, beta-lactamase plus as well as macrolide. How will you differentiate between the two if you are still suspecting a drug rash? Do I stop both drugs or one drug, or which is more likely to be the cause?
Okay, so a lot of times then you have patients with multiple possible culprit drugs, especially for patients who are very sick. They're started on multiple antibiotics at the same time, they're in ICU and they get everything at once. In that case, you want to go on the temporal you want to go firstly on temporal sequence, that's if they are started at different times. If they are at the same time, then you look for drug notoriety. So how likely is this drug reported to cause this particular rash? So if, for example, you are looking at you have like an allopurinol, and then you have like something like very benign like amlodipine, then of course you're more likely to blame the allopurinol. Based on the severity of the rash, if it's like a very mild maculopapular urticarial rash, actually you can just opt to just hold off one or two first and see if the rash gets better instead of stopping everything at once. But if it's a severe drug eruption like SGSTEN, then we usually advise to stop everything, even those that may not be very likely.
Okay, thank you. That's really helpful. Okay, maybe the next question would be the approach to a blistering rash. So in my mind, there's for vesicular rashes, all I know is probably chickenpox and zoster. And when it's a bullous rash, all I think about is pemphigus or pemphigoid. So could you enlighten me on what there is more to these differentials?
Yeah, so we always get referrals for bullous pemphigoid, then it's not bullous pemphigoid. So I think one tip is that if it's an acute onset of blisters, it is most likely not bullous pemphigoid. It's most likely something else, but of course you can have the first onset of bullous pemphigoid. So what are the common differentials that you want to think about? What causes a blister? A blister is caused when there is a lot of fluid that's leaking into the skin. That can come from things like edema, infections like cellulitis, fluid overload. So whenever the skin is like puffy or swollen, when it leaks into the skin, that can form blisters. So a lot of times, the most common diagnosis that we see in a blister patient, but not bullous pemphigoid, is like edema bullae. So especially when you only see blisters on the shins and it looks a bit swollen, it is more likely not bullous pemphigoid. So look for things like edema and cellulitis. So bullous cellulitis is also something that's very common when you have so much inflammation. The clue also is the location. For bullous pemphigoid, very often you have involvement of the acral surfaces, the palms and the soles, and you have usually multiple blisters. So if you see multiple blisters on the palms and soles, that's more likely bullous pemphigoid. If you see like 2 or 3 scattered on the shin or one solitary one somewhere on the body, then it's a bit unlikely to be bullous pemphigoid. The other thing you want to look at is the base of the blister. So we always talk about whether the blister sits on an inflammatory or non-inflammatory base.
Okay.
For bullous pemphigoid, the blister sits on an inflammatory base. That means the skin below the blister and surrounding it is erythematous. If you have cellulitis with a bullae, then the baseline skin will also, of course, be erythematous. But for the most common differential, which is edema bullae, then the baseline skin is very normal and not erythematous, and that can help you differentiate it.
Okay, thank you. That's useful. Any questions that you have, Sean, about bullous lesions, or should we move on to vesicular ones?
I mean, do we actually need to work up the bullous lesions over, like, say, a weekend? So some people would say, let's send off some serology, or let's like not touch the lesions until dermatology sees on Monday. Is there anything that we should do over a weekend, for example?
Okay. I think there's actually no rush to send off serologies, especially if you plan on referring the patient anyway, because the serologies don't come out so fast. So even if you order over the weekend, when dermatology comes to see, it wouldn't be out. But the serologies that Sean is talking about would be things like the BP 180 and 230, and the cutaneous indirect immunofluorescence, which are quite helpful tests that dermatologists sometimes order. One caveat, but it also depends on your comfort, is that if you think that something is most likely not bullous pemphigoid, like you think most likely is the edema bullae, and you're not so keen to refer, but you're also like not very sure, you don't want to miss, and you're managing the patient for a while, or for example, if you're a patient in like outpatient clinic, you can choose to send the BP 180, 230 and the cutaneous indirect immunofluorescence yourself if you're comfortable. And if that comes back as negative, that is pre-suggested that your condition is not bullous pemphigoid, it is edema bullae or something else.
So these are blood tests, is it?
Yeah,
Okay.
they're blood tests.
Okay.
Usually for dermatology, sometimes we do the blood test as a way of like, we don't really think it's bullous pemphigoid. We don't really want to biopsy the blister. We just do the blood test, and if it's negative, we are like, okay, that's fine. Sometimes also, of course, the patient's very old. We think it is bullous pemphigoid, but we don't want to biopsy the patient because the patient is quite old. Then we also just do the blood test.
Okay, got it. Okay, I think that's really helpful for me. So maybe we can talk a bit about vesicular lesions. So beyond chickenpox, if it's everywhere, and zoster, if it is just isolated, what else do we need to think about? Or is that correct in terms of my approach?
Yeah. So for vesicular rashes, the pathophysiology of a vesicle actually is just like a small fluid bubbles, like a blister. So you are right. The most common cause would be like the herpes infections, like HSV type 1 or type 2. That's if it's a localized cluster of vesicles, or if it's disseminated, then it's like disseminated zoster or chickenpox. There are some rarer conditions that can also have vesicles. For example, some reactive causes like gynotic crusty or certain drug rashes. Very rarely, sometimes also cause a vesicular or pustular kind of eruption, but these are generally a bit less common. As a good start, if you're keen to manage like your own zoster patients or herpes patients, you can always just prick the vesicle and send a swab for whatever they think it is, HSV or VZV PCR.
Okay, thank
The
you.
location also would usually give an indication about whether we're looking at herpes or whether we're looking at like a zoster rash, wouldn't it? Because zoster usually more dermatomal compared to something like a crop of vesicles, which is more like a herpes kind of eruption.
Definitely. I think it's quite common. We do see it quite commonly in the hospital because patients are sick, they're stressed, and then they get crops of like reactivation of herpes infections or zoster, and it's quite commonly seen. Yeah.
Okay, thank you. Okay, next, maybe we can move on to some of the common dermatological disorders. And through this, hopefully, we would be able to gain some skills and tips in terms of making sure we identify it correctly and to commence initial management. So let's talk a bit about eczema. What are the defining features of eczema?
So eczema defining features is like recurrent itch, thin scaly plaques. Sometimes they are weepy, they are wet when they're infected.
Okay. And perhaps you could give us an overview. I mean, to me, eczema equals to moisturizers and steroids, and if it looks infected, antibiotics. But yeah, I think that's all I can master.
Actually, I think eczema is pretty simple, exactly what you said. So moisturize very regularly. The problem sometimes is the discoid eczema, or when they are infected and it's very wet, then you don't want to apply so much moisturizers. In fact, when you have very wet, discoid, weepy lesions or infected lesions, then we do want to dry them up with some PP compress, potassium permanganate compress, for example, some antiseptic washes to just decolonize some of the bacteria. But in general, moisturizers are the mainstay. Then the next thing would be topical steroids. So topical steroids, there are different strengths and different parts of the body. You can use a different strength that is suitable. Usually in the acute phase, we sometimes, if it's infected, give a combination cream. For example, we use Fusicort or Fobancort, which comes with fusidic acid and a topical steroid. But of course, you try not to use these for too long because it does breed resistance if you use the antibacterial component indiscriminately.
Okay. I have two practical questions to ask. The first is, how do you do the PP wrap practically? And secondly, these patients may have multiple creams. So how do you put the steroids and the moisturizers together? Do you space them apart? Yeah. Could you help me along with these two questions?
For PP, potassium permanganate can either come as like crystals, which is in its most concentrated form, or already pre-diluted for you into a solution. So depending on what form it comes in, then you dilute it as necessary to like a light pink kind of solution. What you can do is we usually soak a few pieces of gauze or something that absorbs the PP, and then we leave it on top of the weepy lesions for about 10 minutes. So that's called PP compress. And that dries out the lesion because PP is a bit of an astringent. Sometimes we also have PP soaks or PP wash, is when you feel like a tub or some bath with the PP crystals and the light pink color, and then you soak the area inside for about 10 minutes, or you rinse it off, and that helps also to dry up the lesion. So that's for the PP compress or PP soaks.
Okay.
The PP soaks in particular quite useful for people with like quite bad tinea and it's very macerated. Sometimes they got like blisters. Then hard to compress your feet. So we like you can ask them to soak their feet inside this PP solution to dry it up a little bit and it can get between all their web spaces.
Okay. And you do it like twice a day, once a day? How
You
frequently?
do it twice a day when it's bad.
And you mentioned about a 10-minute soak.
Yeah.
Okay.
Then the moisturizer part, right?
Correct.
Yeah. So it doesn't really matter, honestly, which way you put it. Sometimes we even ask them to mix it together and then apply it on together. Like when you do in wet wraps, we ask them to mix it. But otherwise, what we usually do is ask them to spread it out by 5 to 10 minutes so that one layer gets to absorb first before the other layer. It also depends what you're using as the moisturizer and the steroid. If you have one that is very oily, you probably want to leave that the last. So if you have one cream and one ointment base, then you apply the cream first and then the ointment after. You can have like steroid ointment. You can also have moisturizers like paraffin that are more oily. So you just want to put the oilier one a bit later.
Sure. So steroid first or moisturizer first doesn't matter so much. It's more of the preparation that would depending on how well it'll stick, correct? Okay, sure.
I guess the question would be, is there a difference between the kinds of moisturizers? Because I mean, here in NUH, usually we have QV cream, which the nurses can order. But is there something else we should be looking at? Or is there some that are better than others?
People love to ask this question. So if you talk about price, right, the cheapest would be that of aqueous cream and urea. Most of these are like few dollars for a tube, and those are the generics. Those are the cheapest. Sometimes, however, it can be a little bit irritative. Some people find it a little bit irritative, and some people find the urea cream, for example, a bit too oily. So then we use QV cream mostly because although it's a bit more expensive, it tends to be less irritative. But definitely choosing whatever moisturizer you want to give, whether it's aqueous cream, urea cream, QV cream, Cetaphil, Physiogel, they're all okay. Physiogel is probably even more expensive. So, well, it's patient preference, so what they like.
Okay, thank you. Next, we'll move on to fungal rashes. So I think we do see this fairly commonly too. Maybe you can give us an overview of what are the big groups of fungal rashes that we see and their defining features.
So I think that well, we talk about cutaneous fungal infections, so we'll leave out the deep fungal and invasive fungal infections. But for cutaneous fungal infections, the most common would probably be the dermatophyte, which would be like the tinea corporis, one annular scaly plug in the trunk or the fold, the flexures. And the other very common group would be the candida group, would be like cutaneous candidiasis. And then the other one would be like malassezia, which would be like Pityrosporum folliculitis, that is probably the third most common. The morphology is very different. So for tinea corporis, tinea pedis, tinea manum, which is caused by dermatophytes, they tend to be annular, scaly, and those are the ones that have a peripheral annular active rim, and then sometimes a central clear ring. For the candida and malassezia, we usually tend to see that more of like erythematous papules and pustules. Also, common location would be like the folds, the inframammary folds. Very characteristically, when we talk about cutaneous candidiasis, we always talk about having satellite papules. So you have this erythematous plug of confluent papules, and then on the surrounding, you have like studded papules. These are called satellite papules, and they're quite characteristic for candida.
Do they tend to be itchy for candida?
Most of the time, fungal rashes are itchy, but it doesn't always have to be.
I see. So I guess because a lot of these things happen along the flexural regions, eczema also tends to happen along the flexural regions sometimes. So practically, how do we differentiate them?
Yeah. So, well, you can have like eczematous rashes affecting the flexures. We usually call it more like an irritant dermatitis or intertrigo, which is caused by occlusion, maceration, irritation. It can be quite hard to differentiate. So usually we do a fungal scrape, and if you see fungus, then it's fungal. If it's not, then we just call it intertrigo, which is like an irritant form.
And for malassezia, how does it look like?
So malassezia species would cause most commonly will cause things like Pityrosporum folliculitis. There are some, even seb derm can be caused by Malassezia species, but probably the one that we see most common and most linked to Malassezia would be the pit folliculitis. So those you see like monomorphic pustules, usually over the seborrheic areas like the chest and the back.
Okay, thank you.
So between discoid eczema and say tinea corporis, I mean, besides the fungal scrape, is there anything else we can look to differentiate between the two, assuming that we can't get a fungal scrape over a weekend, for example?
Tinea or dermatophyte infections usually are very dry. They are, I mean, those on the trunk, they are not weepy, they're not oozing. Whereas discoid eczema, they tend to have a lot of oozing. If you put like a gauze on it, when you try to remove the gauze, it will be like crusted, a lot of serum. Whereas tinea, if it's not on the folds, it tends to be quite dry. So that's another helpful way.
Okay. Could you give us an overview of the treatment for the different types of fungal rashes that you have mentioned?
So actually treat fungal infections very easy. I just give everyone fungus cream and an antifungal wash. So the cheapest antifungal cream that you can get will be miconazole cream. You can also have miconazole powder. You can have clotrimazole cream, terbinafine cream. But I think that the most commonly used one is miconazole cream.
Okay.
Usually we advise them to use it twice a day. And then we advise ketoconazole wash, which can be applied once or twice a day, and we usually ask them to leave it on for 20 minutes before washing off. So not so much like just use like a soap.
Okay.
To order ketoconazole wash, actually in the system is ketoconazole shampoo, but it's meant to be used also on the body.
Okay.
Yeah.
I see.
Then usually after if you give a trial of topical treatment for a few months, it's not better, then you can consider oral agents, but we usually recommend some form of dermatological input because maybe you got the wrong diagnosis or the patient's using the creams wrong, that's why it's not improving.
I guess the question that usually comes out in the ward is, do we order the cream or do we order the powder, especially for miconazole?
Tricky, right? So usually for the groin folds, sometimes we actually prefer, well, it depends actually. Sometimes if it's very wet, then you don't want to apply more powder because you might think that wet you want to apply powder, but sometimes when it's wet and you apply powder, it becomes very cakey. So in that case, sometimes you want to apply a cream. But for things like some people for tinea pedis, if it's not very, very wet, but it's an area that sometimes can get wet, then we usually use powder. But it's very physician dependent. Definitely for truncal active lesions, we prefer cream because they stay on longer.
Okay. Does miconazole work for dermatophyte infections, candida infections, and your pityrosporum as well?
Everything.
Okay.
Very
And
good.
is there any role in changing away from miconazole, or if it doesn't work, miconazole cream, then if it's truly fungal, you should consider oral?
Usually not. Sometimes for dermatophyte infections, if you know that's a dermatophyte, not a yeast, you can try terbinafine, which works for dermatophytes but not for yeast like candida. But usually, personal experience, I find that it's not very helpful to switch from one antifungal to another. It's more if the patients want it, you don't really want to give them oral agents because of the liver side effects, you can try.
Okay. And
are there any risk factors for development of this kind of history that we can do to prevent it in a ward setting?
The fungal infections, is
Yes,
it?
the fungal infections.
So we always advise to keep the area dry. When the nurses wash, if they can dry the area in between, let the area air. A lot of times for very bad like diaper dermatitis, we do cradle nursing, so we just tell them to leave the like diapers open, but they cover a cloth over the groin, so at least it's aerated. That really helps. Yeah.
Okay. And how long do we expect them to be treated for before we say it's like refractory? And when we consult patients, how long do you expect things to get better after you apply the creams?
I think it's arbitrary. I'm not sure if there's any guidelines, but usually we'll say for at least like 2 months of regular usage. And then if it's not better, sometimes, however, if it's very extensive at the onset, we also do give oral antifungals at the onset. So it also depends on how extensive it is and how bothered the patient is by it.
Okay. And in terms of maybe another group that we do see not infrequently would be like nail-bed fungal infections. How do we deal with this? Because the powders and creams don't stick that well, I'm guessing.
Yeah, correct. So, but one thing first about nail-bed fungal infections is that a lot of times abnormal nails, people like to say that it's fungus, but it's not. So when you have nail dystrophy, and nail dystrophy can come from things like trauma, not overt trauma, but like just shoes that are too tight in general, or if patients do a lot of running, or if they have eczema around the nail folds, the nail would just look thickened, it will look keratotic, sometimes there's a bit of discoloration as well, and that's just dystrophy, it doesn't really have fungus. So that's just what to be careful of. But if you do see like, you know, what clearly looks like fungus, like a bit of whitish superficial discoloration, you can try clotrimazole solution, which is an antifungal solution. Dip it as much as you can into the nail fold, the surrounding area, the nail itself. Something that we have specially formulated for the nail is called a morolafin lacquer, or the brand name is Loceryl, Loceryl. It can be prescribed in our pharmacy. It's once a week and you apply it like a nail polish. Very safe, not much side effects, so you can just prescribe it if you need it as well. But it's a bit expensive. I think it's $70 for a bottle, but it lasts quite long.
Is it available in patients?
Yes, should be.
Okay, cool.
Should we send the nail clippings for fungus?
So I think down to the whole idea of diagnosing fungal rashes yourself, I think that's fine. You can scrape for fungus rashes yourself. You can send for nail clipping. So in dermatology, when we send for nail clipping for fungus, we would send for the fungus smear, the fungus culture, and the dermatophyte PCR. Because the dermatophyte PCR has a higher sensitivity. The problem is that it's very expensive. If you do all these three, it adds up to like $200. So you may not want to anyhow order if you're not very sure that it might be a fungus infection also.
I see. Okay. Okay, so there's probably a question about not sure, could be eczema, could be fungal. Can we give like Triderm or Combi cream?
So I think I have nothing against combination creams, but you must be careful what combination creams you use.
Sure.
So we ourselves give a lot of Dactocort, DAKTCORT, which is miconazole and hydrocortisone. And that's fine because if it's fungus, you give a bit of hydrocortisone, it's okay. But a lot of the combination creams like Combiderm, Triderm, the steroid component is very strong. Like we see something like betamethasone dipropionate or betamethasone valerate 0.1, those are considered more potent topical steroids, and it would be inappropriate to give these for fungus infections because the steroid potency is a bit too strong. You lead to tinea incognito. So I think we don't give Triderm, we don't give Combiderm, but we do give things like Dactocort, which is the steroid potency is milder, and it can help with your fungus and your eczema. So
okay, thank you. Okay, so I think talking a bit about diagnosis of some of these skin infections and doing the scrape, I'm not sure whether this is the best platform, but you could take us through. I've never done dermatology, so I'm not sure like if you have to ask me to do the scrape, I'll tell you I'm not sure how to do it. So maybe you could share with us.
Okay. So in dermatology, we ask for a lot of skin scrapes. Usually we try to do it ourselves, or we have a derm technician, but sometimes we're not around, and then we will ask a team to help us with the skin scrape. Something I need to emphasize is that if you scrape properly and if you scrape poorly, the difference in yield is a lot. So I think it's a good platform to see how to properly do a skin scrape. So first is preparing the material. In the clinic, we have a blunt scalpel, but in the ward, you don't have a blunt scalpel. So what we usually use in the ward is the back end of a sharp scalpel. So that's considered the blunt end of a scalpel, because what you want is a surface that can shed some of the top scaly parts, but not cut into the skin. So we usually use the blunt end of a scalpel, the back end of it.
Okay.
And in terms of where you scrape the skin onto, you can scrape it into any piece of paper, and then you fold it up into four. So you fold it into half, and then you fold it again the other way into a half. Once you scraped into the middle, and then you just stuff the whole thing into a white color sterile specimen bottle. If you have a circular filter paper, that's also good. You just scrape into the middle of a circular filter paper and just fold it itself like a funnel. Essentially, just create like a pouch, and then your skin is in the middle. And you put it in the middle, and then when the lead tap opens it up, your skin is still in the middle of the piece of paper. Yeah.
And how much do you need, to get any yield in terms of the tests?
The more the better, but at least So sometimes the skin itself is not very scaly. No matter how you scrape, you don't see very much. But at least if you can see some bits of skin on the paper, that's enough. Yeah.
Okay.
The
And
other hmm.
sorry, go ahead.
The other thing I forgot to mention is that you have to prepare the skin first. So usually when we ask for fungal scrape, we try not to have like miconazole applied or any form of antifungals applied first because that will affect your yield.
Okay.
Secondly, you have to wipe the surface first because a lot of our skin, we have normal fungus living on it, and that is a comment, so it's fine. You don't want to pick up those. So you want to wipe the alcohol surface first,
Okay.
and then later when you scrape, you're actually getting the fungus that is like on in the stratum corneum, so not on the surface, but actually part of the skin, and that's the most important.
Okay. That's really helpful.
Do we scrape asymptomatic areas? Because, for example, in scabies, you would scrape all the wet spaces, not just the affected areas. But for fungus, is there any difference if you want to scrape all the folds, for example, in the groin?
Usually no. Usually you just scrape the area. So where you scrape, if there are a few rashes, you want to find the area that's the most active, most red, and most scaly. So if you have a scaly plug, usually it's the margin of that ring, and you can scrape from a few locations. That's fine, especially if the rashes are looking similar and you can't seem to scrape enough. You can just scrape from different areas, especially the morphology is the same. That's fine to increase your yield.
Okay. So next, maybe in terms of like pastels or vesicles, how do we go about getting samples for those?
So you scrape a pustule, for example, if you want a fungus smear, if you're thinking of pit folliculitis, or if you want to prick a vesicle and send for HSV. The way is quite similar. You try to find the juiciest, biggest lesion that you can see that looks like there's fluid inside because you want the fluid. Same thing, you swab the surface and then you need to prick the pustule to get the fluid to come out. So usually when we prick, we take like a small blue needle and you just lance the surface. So the picture on the left that you can see is some guy showing how to lance the surface. This is a zoomed up image, but what you do is you poke the needle through and then you push it up and that will break the top of the surface. Then you take a swab and then you just swab the juice that is coming out. You might need to use a swab to press on the pustule to get everything to expectorate through that nick that you made in the surface.
Okay, got it. Okay, maybe for the third condition of psoriasis, could you share with us what are the defining features and how do we treat these lesions?
Yeah. The typical psoriasis, which is your chronic plaque psoriasis, is defined by these 7 pink plaques with the silvery adherence scales. I think these are generally quite easy to recognize. There are some forms like guttate psoriasis where the plaques are a bit smaller. That might be a bit harder to diagnose. Usually psoriasis, we also always want to look out for whether the patient has any psoriatic nail changes, scalp changes, and any psoriatic arthritis.
Okay. And in terms of what do we apply for these? Is it steroid creams or what would you advise?
So the first line for psoriasis, as for eczema, is topical steroids. There are many different types. They come in different potencies and in different combinations. In psoriasis, you might have heard of this medication called Divobat. Divobat is a combination between a steroid, betamethasone dipropionate, and calcipotriol, which is a vitamin D analog. So vitamin D analogs can be used for psoriasis. That's why they make this combination. Other things that you can use would be things like coal tar. Coal tar, we most commonly know it as a shampoo, but some places also have coal tar cream that you can apply to the body.
Okay. For the shampoos for those with, let's say, scalp lesions, how frequently should they be applying these shampoos?
Usually we say for things like coal tar shampoo or selenium salt, like Salson shampoo or cetrimide shampoo, we usually ask them to use it 2 or 3 times a week because sometimes if they use it a bit too often, it can be a bit drying. Yeah.
Okay.
Is there anything in particular that we need to look out for, like pustular psoriasis that requires an emergent referral to dermatology?
Yeah, very good. So there's the psoriasis, there's a few variants that are potentially dangerous with mortality. One would be like what Sean mentioned, which is pustular psoriasis. Within pustular psoriasis, actually many variants of SOLA, but the most worrying variant is what we call GPP, generalized pustular psoriasis, where they just erupt, the whole body is red and in pustules, and they are usually febrile, and they can be tachycardic and hypotensive, and often they're managed in an intensive care setting. Other condition in psoriasis is what we call erythrodermic psoriasis, where the psoriasis also affects the whole body, just that it's not pustules, it's all plaques everywhere. And that also itself can be associated with some degree of hemodynamic compromise. So those two are the ones to be cautious about.
Okay, thank you. Okay, next we shift gears a bit. So steroids are something that that we see very commonly in dermatology. But I think one of the problems is that we may be giving it inappropriately. So I see that you've prepared a table here. Could you just take us through practically what are the principles? And yeah, I mean, generally what you prescribe for different parts of the body or for what conditions?
So I think first you think of, there's a few things you think about. First is the age group of the patient and the nature of the skin. If they're very young or very old, then you want to use something that is weaker and more gentle. Then you want to look at the location. So for areas that the skin is already very thin, like the neck, the groin, the genitalia, or the face, then you also want to use a weaker topical steroid because of the risk of steroid atrophy. Then areas to avoid steroids on would be the face, and especially the periorbital area, because too much steroids there can cause cataract and glaucoma in addition to your usual steroid side effects. Then the last thing you look for is the thickness of the lesion. And generally, if a lesion is thinner, then you can use a more gentle steroid. If the lesion is thicker, you might want to use a thicker steroid. So in the table here, divided into low, moderate, and high potency. Generally for, as a first-line treatment, if you're seeing the patient, we recommend starting with either a low or moderate potency steroid. Try to avoid the high ones because they may be misused, or you might be treating the wrong thing, like you might be treating a fungal infection by thinking it's eczema, for example. So we recommend starting with something that's low or moderate.
Okay. That's helpful. Sean, do you have anything else to ask about steroids?
Is there any point in learning about fingertip units for topical steroids?
Yeah, okay. I guess that's also more for like a patient counseling thing. So how much topical steroids to use? Because pharmacists usually, or most people actually, will tell patients to use very thinly and very sparingly. A lot of patients don't know how much that is. And often in our experience, we find that very thinly is actually too thin. It's like not what we expect them to be. So there's this concept of one fingertip unit. So if you have one fingertip and you squeeze a standard tube along this fingertip, that is supposed to cover 2 palm-sized areas of skin. So actually, if you try it like with moisturizer, actually quite a bit more than you might think if you were to apply it thinly.
Okay. Okay.
So lotion versus cream versus ointment, that's also something that people like to ask about. Which one will you choose and for where?
Okay, so if you think about it, so lotion has alcohol inside, that's the most runny. Cream is in between, is a bit more solid, and then the ointment is more oily, and that tends to be something like for example, paraffin. So in terms of the potency, for example, you can have betamethasone valerate 0.05 as a lotion, cream, or ointment. The lotion will be the lowest potency because that evaporates and dries off very fast. And the ointment would be the highest potency because that stays for very long. So something that you might want to take into. Then we talk about usually when do you use lotion, when do you use ointment. So lotion, we use it in areas that are very large and you just cannot afford to apply so much cream everywhere. Then we use a lotion like Alomet lotion, and then it's easier to apply on. For scalp or for very hairy areas, usually we give a lotion as well, because if you give a cream or ointment, it'll just get caught in all your hair and then you cannot get onto your scalp. We use ointment for when the area is very thick and you just want the potency to be enhanced a bit more, then we give ointment. Like for example, palms and soles is very keratotic. So if you apply an ointment, it stays there a bit longer.
Got it. In terms of frequency of dosing, usually we just give twice a day, or it depends also on the thickness and things like that.
By default, it's twice a day, but when we're asking patients to taper off, for example, as the rash gets better, we usually ask patients to slowly stop rather than to stop completely all at once because the recurrence is higher if you stop completely. So when we ask them to taper, then we ask them to reduce from twice a day to once a day to every other day and slowly stop like that.
Okay, thank you.
Is there a role of any topical steroid sparers? Or I guess there are two parts to this. One is there any topical steroid sparers? And two is, when do we consider oral steroids if we're talking about steroids in general?
Okay, so first about the steroid sparers. So there's this group of steroid sparers in a cream form that's available now, which are tacrolimus inhibitors like Protopic and Elidel. There are probably going to be new ones in the market, but for now, this is what we have. These, they don't contain steroids, but they have an anti-inflammatory property that is equivalent to probably a low potency steroid. So we usually use things like Protopic and Elidel for the eyelids, the face, or the genitalia where we don't want to use too much steroids. But they are quite expensive also. They're about $70 for a tube. So you might want to probably just be careful about using it because it's quite expensive and you may not really know whether you're treating the right thing, for example. In terms of oral steroids definitely work a lot faster than applying creams. So they can be considered for acute eczema flares, and the dose will also depend on how bad the flare is. If the flare is very bad, we can give like half mg per kg per day and then slowly taper off. If it's not very bad, but you just want a little bit of extra booster in the treatment, you can give a lower dose, like just 10 mg a day for maybe 5 days, and then 5 mg a day for 5 days and stop. That will be a very small dose.
Okay, thank you. Okay, for the last segment, when to worry. And in terms of worry, I think number one would be dermatological emergencies, and number two, for skin lesions, when do we need to suspect that it's not something benign?
Okay. For dermatological emergencies, I think the main two that is very important to pick up would be the SGSTEN as well as DRESS, or the new name is also DHS, drug hypersensitivity syndrome, because these two drug reactions are really very potentially life-threatening. I think most residents are able to look out for mucosal involvement, and when there's mucosal involvement, everyone panics, which is good. It's good to panic. So definitely when there's mucosal involvement or when there's skin erosions, then you want to be very careful whether there's SGSTEN. An earlier sign before the skin actually erodes is that the rashes become more dusky and look a bit necrotic. So the reason that you get mucosal involvement and Nikolsky sign in SGS because the skin is necrotic, the skin has died. So before the skin has truly died, usually it becomes a bit purplish hue, a bit darkish brown, like early gangrene kind, and that's a sign that you worry. Skin pain is also a very important feature because that's a sign that the skin is dying. And if patients have skin pain, then you want to be very concerned whether this is a drug, like a severe cutaneous drug eruption like SGSTEN. Yeah. For DHS, something that's very prominent about this condition is that it tends to involve various organs like kidney, liver. We recently had a case where the patient actually first presented as pancreatitis because she came in with abdominal pain and raised amylase. So, and the patient turned out to have drug hypersensitivity syndrome. So DHS can present with a lot of things. So apart from liver, kidney, pancreas, can also affect the lungs. It can present as a pneumonitis. It can also present as an MI with myocarditis. So it really has a very varied presentation. Sometimes the rash is not even very obvious itself, but this is why you have to look very closely for any erythema on the patient's body.
Okay. So does the fact that the name has been changed from DRESS to DHS mean that eosinophilia may not be present?
Exactly what you said. So there's a criteria called the registrar. It considers various organ involvements, the nature of the rash, and also eosinophilia. But eosinophilia is not a necessary feature. If you have enough other features, you can still meet the criteria for drug hypersensitivity syndrome.
So basically, to think about it is when there's a rash and a patient with multisystemic involvement, that's when we may want to consider DHS as a differential.
Correct.
Okay, thank you. Do you want to say anything about AJAP that's here in the slides?
AJAP is relatively rare. I mean, we don't get that many cases a year, but essentially when you see pustules, you can refer to us last. Most of the time you think about fungal infections like candidiasis, but when you have it in like funny locations or very acute onset in the flexures, and one difference is that for AJAP, the pustules are very small and the skin is red. The underlying skin is like one plug of red and then small pustules on top. Whereas for candidiasis, usually the skin is normal and then you just get solitary pustules scattered on normal skin. So that's a bit of a differentiating feature.
Okay, got it. Maybe we could talk about when do we need to suspect things like skin cancers in terms of when we see skin lesions?
Yeah. This is a very big category, but
what are the red flags? Because I mean, some patients you may notice something over the skin. What are some of the red flags that we can just pay attention to?
Anything that is changing in size and anything that is bleeding or ulcerated. I think these two are definitely the most high yield red flag symptoms. Okay. Any pigmented lesion on the face, especially around the nose area, this area here, pigmented and pearly looking is very high risk for BCC. Okay. Yeah. I can also just share the most common referral that we get for query skin cancer that's not skin cancer is a seborrheic keratosis. Yeah. It is growing and it's brown and people think it looks like a melanoma. It's hard to describe how it's not. It tends to have a very warty, verrucous surface. And then for dermatologists, when we see it, we know like in 2 seconds the SEPK. But I guess for trainees, it can be very difficult. You can look at more pictures of a SEPK and then maybe that will help you to differentiate.
The pictures to the summary notes and hopefully that will help you save some SEPK referrals.
Yeah.
Okay, Sean, do you have any final questions before we wrap up?
I mean, so for things like SCC or say like Bowen's disease, which is like SCC in situ, I mean, and it's always it's always confused with very severe eczema. So when we'll be concerned about that kind of situation?
So I think the most differentiating feature is that for Bowen's or SCC, you see in an older patient, whereas for eczema, it may or may not be older. And the second thing is that eczema, if you have eczema in one area, like one patch of scaly skin, then you might want to reconsider whether that's really eczema. Eczema, you usually have it in a few locations, whereas for Bowen's or SEPK, you really just have one solitary plug and then it's scaly on the top. Sometimes if you have SCCs that are a bit more advanced, when you feel the lesion, it feels more indurated, like it's grown a bit deeper, whereas eczema would be very surface. But if it's like Bowen's, which is SCC in situ, both of it may not feel very indurated at all.
Okay, got it.
I guess one other question that happens in the ward is people ask, should we start the steroid first, like say over the weekend, and then wait to, and would it affect dermatology's diagnosis, say on the weekday when they finally get to refer this patient?
Would it affect the diagnosis? Probably not, especially because now very good residents usually take photos at the onset and then they upload it, so usually doesn't affect the morphology. It's just more of whether you're confident enough with regards to the diagnosis. If you're confident that this is an eczema flare or a bullous pemphigoid flare, you can start the steroids if you're comfortable. Just a reminder here that we do not treat psoriasis with systemic steroids, because if you stop systemic steroids or you taper it too fast, it can flare a pustular flare of psoriasis. So we don't give systemic steroids at all for psoriasis. So if you have any doubt on the diagnosis of eczema or you're not very sure what you're treating, it's fine to hold off. But you can always institute some topical steroids yourself. There's no problem with that. Yeah.
I guess one last question actually about the photographs. What is it that you want to see in the photograph that is important? Because sometimes we take it and then people say it's very lousy. We can't make any diagnosis based on this.
I was going to mention something about the photographs too, because there are good and bad photographs. So first thing I think is the lighting. The lighting is like half the battle won. A lot of the wards, they're quite poorly lit. Then once you draw the curtain, you really can't see anything. So if you could get good light, that would help. Secondly, especially if you're making a telederm referral for people at AH, we usually want a combination of far away shots and close-up shots. So far away shots give you an idea of the distribution of the rash and the extent, whereas the close-up shots will give you an idea of the morphology. The problem about a lot of close-up shots is that they are very poorly focused. So when you're taking the picture, just be careful to make sure that it's focused, you're not moving, and the image is clear quality, and you're able to see the surface changes, which is quite important.
Okay, thank you. I think these are all very practical tips. We'll try to give you better photos in future. Okay, I think we've discussed.
Can I mention?
Yeah, sure. Go ahead.
Okay. I didn't mention just on a drug chart, which I wanted to mention. I think one way that you can create a drug chart very fast is you go to the all medications tab, and then you click the name so that it filters in alphabetical order all the medications given, and then from there you just go medication by medication and chart it out. Some people, they like to go day by day, but then it's very painful because then you have to go through like many days. So in that case, it's better to just go to the all medications tab and filter by name. Then some people say, can I not do the Excel? Can I just type it out in Microsoft? Type it out in CPSS notes, right? That is fine if you have very limited number of medications, maybe less than like 5 or 6, then it's quite easy to read if it's just 5. But if you have many and some of them like start, stop, then an Excel format would be easier.
Okay, got it. Yeah, maybe at this point it's we can then have some take-home points for the residents. Yeah, what take-home points do you have, Ellie?
Take-home points. First, I think I feel that dermatology is quite a challenging subject for many residents because you do need a certain amount of knowledge and certain amount of having seen enough to be able to recognize it. A lot of times, I think we don't teach very well because we're not able to verbalize why we think a rash looks like something versus something else, because ourselves, we have learned it just by looking at thousands of it. So that's why we also are not very good teachers. But I think looking at rashes and first getting to a practice of describing it when you make a referrals would be good in terms of your own learning. I think taking good pictures is also very important. And lastly, if you need help with if you want like informal consults, you can also let us know. If you are unsure about why we suggest certain things, then you can let us know as well. Otherwise, I think everything's in your slide.
Okay, thank you very much. I think it's been a very fruitful session, and I'm sure the residents will also learn a lot, and hopefully we'll be able to give you better referrals in future. Thank you.
Thanks, Ellie.